Okay, good morning, everyone, and Happy New Year to everyone. I'd like to congratulate you on having passed obstetrics and several years that we haven't had a full everyone passing in our course. No? And thank you for your diligence, and I hope that you persist during gynecology. No? So, di ko naman, anyway, this is we're supposed to have a lecture or probably a discussion if anyone has read AUB. And actually, I posted in Canvas. I had two posts, no, one in files for this lecture, and another one. In the modules you will see for first LE, I posted this lecture as well. Plus, I also posted a case-based lecture, which I did for UP, for TVUP. No? So please feel free to look at that, or you can get the video from TVUP if you want. But the slides are here in Canvas anyway. So thank you very much. Okay, so these are the outcomes for today. No? So it may seem daunting, but it actually is not. No? So differentiation of different types of bleeding, PE. No? Let us look at the physical examination findings that we need to do and what we should expect to help us diagnose AUB. Now, the diagnostic plan, depending on your considerations, you should more or less be able to do that as primary healthcare physicians, no? Something that we want you to be able to develop, no? And of course, management plans, no? So hindi mo naman, sometimes you cannot wait until they go to a gynecologist. So what are the things that you can do as primary healthcare physicians in managing patients who have abnormal uterine bleeding? No? So normal menses is very important. No? So it is 28 plus minus 77 days. No? So that will mean as short as 21 and as long as 35 days for the flow. No? But average should be around 4 days. No? And you are, because you are so techy and everyone is so techy, no? So you must be familiar with some of these. No, the girls are at least anyway. There are some guys who also do this, no, to track ovulation uh, of their girlfriends, no, or significant other, no. So these are how it looks like, no. Some of the apps, no. So when you say abnormal uterine bleeding, of course, abnormal means irregular, no. It can involve frequency, regularity, duration, volume of flow outside of pregnancy. And of course, 30% of women will experience some form of AUB in their lifetime. No? And it usually occurs during the time where transition of hormones happen. And this would be your menarche or your adolescent period, no? And your perimenopause, no? Yung patapos na yung cycles. No? So, okay. Please feel free to raise your hand or basta you can just speak. I don't really mind, no, to ask questions, no. So when we say infrequent episodes, the term that was used that has been used until now is oligomenorrhea, and a profuse menstruation. It is now called heavy menstrual bleeding, no. So hindi na siya dati may in the next slide I'll show you the terminology before. Prolonged flow is more than 7 days, no? Yung profuse flow, 80 ml quantified volume, no? Intermenstrual bleeding can also happen, meaning after menstruation and then you bleed, no? Sometimes you bleed when you are ovulating, although what is normal is just a few days of spotting, no? But if it becomes bleeding, then it can be classified as abnormal. And of course, amenorrhea is an abnormality. However, we are not going to discuss this today. It's going to be discussed in the next few lectures, no? Amenorrhea in itself. So the terminology, as I had alluded to earlier, it varies, it changed, no? When we were studying, we call it metrorrhagia. That was profuse and prolonged. Baka kasi may nagbabasa sa inyo ng mas lumang libro, no? Menorrhagia is the profuse bleeding, and then there is another old term, DUB, no, dysfunctional uterine bleeding, that is after having evaluated the patient, you did not find anything, no. So as I said earlier, the symptomatology is now HMB, heavy menstrual bleeding, no? And we now talk of a classification of PAMCOIN. This is the FIGO International uh, Gynecology and Obstetrics Society. We have, this is the, um, it has been classified as PAMCON. Ano natin. So, when we say menorrhagia, how does that manifest? No, when you soak through, sorry, not you, but rather when the patient soaks through one or more sanitary pads every hour. So that will tell you that this is profuse. There are some patients who need to use 2 napkins to control the, so that they will not have what, quote unquote, the tagos, no? And then needing to wake up, change sanitary protection during the night. No? These are some of the things that will alert you that your patient may have your AUB. Blood clots, no, larger than a quarter. Maybe 1 peso now would be for us, no? And having to restrict your activities because of heavy menstrual flow, then that is also a symptom of your AUB, no? And other symptoms that may be referable to your anemia. Sometimes they have shortness of breath, tiredness, no? We see fatigability, no? So we have had some patients who did not even know that they were anemic already, no? So these are the symptoms. So for a patient, when do they have to see a doctor? So we had already talked about that, no? Bleeding for longer than a week, bleeding between periods, no? So that means your mid-cycle or intermenstrual bleeding, and irregular or any vaginal bleeding after menopause. No, but we don't call bleeding after menopause AUB. We call it post-menopausal bleeding. So in order to say what is the normal menstrual volume, um, there has been actually a very poor correlation between what a patient says, no, what she perceives as profuse bleeding, compared to the really the volume that she may produce, no. Suffice it to say that the average is around 35 ml, and if you have twice that, no, or around 80 ml, no, that is your more than 80 ml, you say that that is heavy bleeding, no, and it usually increases with parity but should not increase with increasing age, no. So yung nice, no, so now it is classified as HMB, is the menorrhagia or profuse bleeding, and usually yung quality of life na more than the actual volume. If the quality of life of a woman is affected, then you can also say that this is an HMB. And although the self-perception, as we said earlier, may be inaccurate, no? Ang problema dito for those patients who are who may report it as such, no, it may result in surgical procedures, no? Because they are so stressed about the volume, no? However, there are, this is how it looks like, no? We have found that this pictorial assessment chart has been more beneficial to us, no? We can have this in our clinics, no? And usually yon, no? If if you look at this one, no, ito yung toilet seat, towels, tampons, no? And then, or if you have napkin, so this would be the appearance of in your napkin of parang to characterize if it is regular or profuse, no? Regular volume or profuse, no? I am not going to ask you to memorize this. This is something that we have in the clinic for the patients to encircle. So we can more or less say that they have HMB. Although for practicality, it's really the clots and everything, and the number of hours that we use to help us say if the patient has HMB. Some patients will use your diaper. So that's something that you have to ask them. Do you use diapers, and how many do you use in a day? So are there questions for now? Okay, so now currently, as I said, no, as far as the NICE guidelines are concerned, patients' reported quality of life has been what is used clinically. No? So is there any clue that you can get from the history? No? As far as the volume is concerned, no? Kung kunyari malakas talaga siya, no? You have more volume, then you think of the uterus as the source of bleeding. Okay, and however, if the patient just reports spotting all the time, no staining, you may or light staining. Usually, it's the genital tract, the lower genital tract, no, or any part of the genital tract. Pero yung pagka yung malakas yung volume, it's usually the uterus, no. You can more or less consider the uterus as the source of bleeding. How about the color? They will come to you saying brownish or reddish, no? A brown stain just means an old blood, no? And this may mean like yung intermenstrual bleeding, and brown usually can mean ovulation, no? A red blood staining may, and again, any other site, no? So postcoital, of course, is your anyone would know what postcoital signifies? Ay, nandiyan na yan pala. So, it's a cervical pathology. Hindi ko pala na-hide. So, so when a patient comes to you with this, no, make sure to evaluate the cervix. No? Or you can have infections, making the genital tract very friable. Okay. Any questions for now? Okay. So, when you see a patient, these are the things that you have to think about, no? Buntis ba to? Because the most common cause of bleeding during the reproductive period is pregnancy. So you have to rule that out first, no? And then, what is the bleeding pattern? Is it regular? So when you say regular, it's every month, no? So it's within the 28 plus minus 35 days. So usually, if that is the case, you may be dealing with an ovulatory bleeding. Ovulatory kasi regular yung menses na. And pag irregular or very prolonged, no? So maybe this is an ovulatory bleeding. Usually patients with polycystic ovaries, no, will have irregular menstruation, and then will develop hyperplasia, yung hyperplasia of the endometrium. So yun yung another cause, no? Should for as far as the labs are concerned, no, when you see a patient presenting with AUB, you ask yourself, should a complete CBC count be performed, no? So, or an endometrial sampling be performed, or a coagulation evaluation be performed, no? So these are the usual things that we ask about. What ano pa yung pwede natin gawin? Investigate, should a transvaginal ultrasound be performed? Is bleeding related to a contraceptive method? No? So these should be part of the questions that you are thinking about while you are seeing a patient with this. No? So when we ask about the LMP, we always ask about the last normal menstrual period, no? The first day. And you ask how many days it happens, no? And then, of course, the intermenstrual bleeding. So ask if it is postcoital, no? And as other associated symptoms, no? If she has any history of OBGYN surgery, you can also ask that, no? Prior CS, a previous myomectomy, you may have AUB, no? A previous cervical procedure, no? Pwedeng cervical image or so there is also a rare condition. It is an AV malformation where it is usually seen on ultrasound. No? So ito yung these are the things that you are going to consider. No? As we said earlier, HMB has replaced the term menorrhagia. No? And now also, why did it have to replace menorrhagia? Because it does not really differentiate between volume and duration of bleeding. Hence, we don't really need to do that. No? So and then it just evolved, no, HMB. And now the pump point classification already has changed the way we diagnose your abnormal uterine bleeding. And the palm point is your polyp, adenomyosis, leiomyoma, malignancy, coagulopathy, ovulatory bleeding, endometrial. So we are talking about the possible causes of AUB when we classify it into your palm point. No? We will go through that shortly. No? So but of course, the things that you have to zero in on your physical examination, tingnan mo muna, pale ba siya, may fever ba, ecchymosis, no? These are things that can give you clues as far as the etiology of your AUD is concerned. Does she have an enlarged thyroid gland, no? A hypothyroidism may be associated with irregular menstruation. Or does she have evidence of hyperandrogenism? Ano yung hyperandrogenism? When you have excessive androgen in the blood, sometimes you have symptoms like hirsutism, acne, male pattern balding. No? So these are things that you look at. No? And sometimes nakita nyo yung minsan obese patients with PCOS, yung back na neck niya, is darker, no? The pigmentation at the back of the neck, no? We call this acanthosis nigricans, no? So galactorrhea also may suggest hyperprolactinemia, which can cause problems in your menstruation. So physical exam, very important, no? What I want you to develop is to have a working diagnosis after your history and your PE. Do not jump directly to an ultrasound exam. We still want you to have that knack, no? And it is a characteristic of a UERM graduate to be able to do this, no? After history and PE, you already have more or less a diagnosis. So your diagnostic plan will not just be everything else that you need to do, no? So that you don't use your diagnostic examination to diagnose everything, no? So you just make sure that after your PE, you have an idea already, no? So for and these are the things that you have to look at, no? Speculum exam, is the cervix friable? Di ba pag na-speculum, makikita mo the cervix, no? And then the vagina, if it's smooth, if you have a problem with that, no? Sometimes it's just a retained tampon, no? Or that may be causing the bleeding. So you have to make sure that you check that, no? And then you can see from where the bleeding is coming from using the speculum examination. You see that it is coming from the os, no? And on your IE and your bimanual examination, I think you've done this, no? During your preceptorial, no? As you push the cervix upwards and then feel until where you are going to be able to palpate the fundus, no? That is your bimanual examination. So you're able to assess the uterine size. So larger uterus may be myomas, no? Limited uterine mobility may be pag hindi mo magalaw yung cervix, no, and yung uterus, that can be malignancy or a prior infection or a previous surgery, no, endometriosis. And of course, if the uterus pelvic mass is present, you can have an ovarian cyst or myoma, adenomyosis rather, that may be present. Pwede rin na myoma. Minsan yung pedunculated myoma will feel like a separate mass, no? And of course, if you have tenderness, no? So PID also, which can cause yung pelvic inflammatory disease. I think you had lectures with Dr. Marta Rosa, no? May also cause bleeding, no? So yun naman, pag when you do your bimanual examination, yung PID, um, you can feel adnexal tenderness, no? And usually we say there is pain on lateral motion of the cervix, no? Because the fallopian tubes are mobilized, no? And so there is some pain. So so you have your physical examination, no? So and then but how do we evaluate your abnormal uterine bleeding? Diba? We do your pregnancy test. So in a non-pregnant reproductive age woman, the goals of the evaluation would be to look at the pattern, the severity, and then finally the etiology of the bleeding. And that will guide us in the management. Now we go back to your pump coin. Diba, ito na yung bago. This is what we used to define what that is how we communicate with each other as far as AUB is concerned. No? Look at the box that I have, no? A polyp, an adenomyosis, a leiomyoma. So look at that. These are the structural or anatomic causes of AUB. Polyp, may nakita ka. Adenomyosis, there is enlargement of one of the layers of the myometrium, no? Leiomyoma, there is a distinct mass intramural. Malignancy and hyperplasia, all of these would be anatomic. And so you look at it is usually therefore diagnosed by imaging, surgery, or a biopsy. The other things there, coagulopathy, ovulatory dysfunction. When you say endometrial, this is the term now for your dysfunctional uterine bleeding, endometrial na. Iatrogenic, meaning this can be oral contraceptive. We will talk about all of these things later. No? So this one, no? So ito, you may be able to diagnose this by history and other laboratory examinations. But of course, you can go through all of the imaging pa rin, so you will not miss anything. No? So let's go to the FIGO nomenclature. So when we say, look at this, I put P1. So what does that mean? That is a polyp, no? AUB because of a polyp. And usually, it is associated with, pero tingnan nyo to, nilagay ko, for example, I put it P1, so may polyp siya. M1 is malignancy, no? Probable hyperplasia, makikita mo yan sa ultrasound, no? A very thickened endometrium, pwede mo siyang i-classify as E1, no? And pag kunyari O1, may ovulation problem din siya. Okay. So this is a patient, pag ganito yung diagnosis ng pump coin niya, these are the probable reasons of the AUB. No? For example, this one, the third example, P1, L1 is a leiomyoma. So be careful, an M is not a myoma, but a malignancy yung M. L1 is a leiomyoma. Okay? So let's go to P, polyp. So these are localized overgrowths of the endometrial tissue seen usually in because of estrogen stimulation. So sino yung may estrogen stimulation? Reproductive age women. No? So there is an overexpression of the endometrial aromatase and gene mutations. Usually these are benign. No? Very rarely is it malignant. And it can be in symptomatic postmenopausal women. Okay, so what polyp siya. So usually seen, there is quite a significant number where it is just an incidental finding, not 12%. No? So do we do anything about pag asymptomatic? We don't do anything about it. We just monitor it. Because especially if it's smaller than 1 cm, it may regress spontaneously. So kahit makita mo siya sa ultrasound, may polyp, tanungin mo siya, may symptom ka ba? Kung wala, yeah, you just monitor. Okay, so it may be related to infertility. So that may be an indication for a polypectomy. if your patient is for IVF, no, even if they are asymptomatic. Now, for symptomatic patients, the gold standard is really hysteroscopy. So you put a camera inside the cervix into the uterus so you can see where the polyp is, and then you remove and do transcervical resection of a polyp, TCRP. So that is how it is done. May questions ba for now? Okay, so this is the appearance of the polyp on ultrasound. You see endometrial glands. Sorry, hindi na to. So yung polyp actually, I failed to put that there, no? But it's usually benign thing, and usually makikita mo siya parang tongue-like projection siya, no? No, so now we go to A, adenomyosis as a cause of your abnormal bleeding, no? So adenomyosis is defined as endometrial glands, no? Ectopic endometrial tissue that is found in the myometrium. Adeno, gland, myo, muscle. Okay? So it may be focal, dun lang, or can be diffuse. Now, usually it's seen in the 5th decade of life, and patients will usually present with prolonged bleeding, no? And sometimes parang hindi siya sobrang profuse, but in very severe cases it may be, no? The bleeding is because the prolonged bleeding is because of the altered uterine contractility. Okay, so kasi yung last phase of the menstrual response, the endometrium and the myometrium and the endometrium actually contract. So your menstruation stops. No? So it has been seen that in your patients with adenomyosis, that may be impaired. No? So who are the patients who are likely to have develop your adenomyosis? Patients who have had previous pregnancies, especially if they have undergone previous DNC, dilatation and curettage, no, or a cesarean section. So any surgical procedure, therefore, that may have disrupted the endometrial cavity. Okay, and immunologic markers, their studies, these are the immunoproteins that they have seen in excess of in your adenomyosis. So how is it diagnosed, no? Ultrasound, no? Usually, ultrasound, Dr. Junio is an ultrasonologist, no? So sometimes they are able to see your vascular cysts scattered throughout the myometrium. It has been said, though, that MRI is more sensitive and specific. However, it is more expensive. So what we do first line is your ultrasound, and this is how it will look like. As we said, there are anechoic cysts that you see here. This is a Doppler ultrasound, the one to your right, no, where you see the blood flow within the muscle of the uterus, no. What is also, if you look at this image also, what it characteristic finding also of an adenomyosis, yung walls ng uterus are not, parang iba yung thickness niya. Mas makapal yung isa. So in this case, it's the anterior. No? But usually, it is the posterior wall. Mas makapal. Okay. So here again, here, the big figure to your right, no? This is MRI already, though. You can see here, can you see my cursor? This is the uterus, and this is the darker, the whiter thing is the endometrium, and the darker area here is your adenomyosis, no? So ano siya, so mas makapal yung posterior of the uterus, no? Okay, so that is how it, and on histopath, this is how it appears like, no? Ectopic, meaning hindi siya, wala siya sa endometrium, but you see endometrial glands, no? There are criteria for that histopathologically, no? More than, anyway, ito na lang, para hindi na kayo mag-problema doon. Ectopic, So now we go to your leiomyoma. Of course, this is the most common neoplasm, uh, pathogenesis of which is not well understood. No? And actually, it is related to estrogen production and genetics. No? There are rearrangements in the genomic regions. No? That is what they have seen. And what we have seen, though, is well, of course, after menopause, it should regress. No? So because you have less of your estrogen. Okay, so the abnormal myocytes are transformed, and there is abnormal growth of these myocytes, no? And some receptors are upregulated, such as your progesterone and your estrogen receptor. No? So kaya ano siya. So this is just an illustration of how uh, a summary rather of how myomas develop, no, and how the steroid hormones also upregulate and increase the size of the myomas. No? So I don't think this is in compregnant. I just made that. No? So the symptomatology, therefore, will depend always on the size and location. And since you had myomas already, no, so as a lecturer ni Dr. Junio, uh, I would presume that she has told you about the classification of the myomas. Type 0 will be intracavitary, type 1 and 2. So anything, don't be scared. Okay. Ito yung itsura ng intracavitary, 0, 1, 2. No? So, and then 2 to 5. Mga 2 kasi to eh. No? So, an intramural myoma that may have come in contact already with endometrium. When we say intracavitary, this is the endometrium that we are referring to. And anything which has come into contact with the endometrium already has a potential to cause abnormal uterine bleeding. Probably because similarly sa adenomyosis that there is impaired contraction of the last phase of menstruation where you are supposed to have contraction of the myometrium and the endometrium that is impaired, no? Kasi nandyan siya. Okay? So usually these may happen in everywhere, no? So ito naman, let's go now to your malignancies, no? When we talk about malignancies, it does not just have to be a uterine malignancy that can cause bleeding, a vulvar, a vaginal, a cervical, an endometrial, a uterine, and an adnexal. So ibig sabihin, all genital tract malignancies may produce bleeding. No? Paano yung adnexal? When you say adnexal, this is the collective term for your fallopian tube and ovaries. No? And when you have, there are ovarian secreting, estrogen, hormonal secreting tumors like your granulosa cell tumors. And then this can produce your abnormal bleeding. No? So, vulvar, very rare cause, and vaginal, no? Very rare cause of abnormal bleeding. Usually with vulvar malignancies, in the early stage, it's usually itchiness and a whitening of the vulva, and the vagina also very minimal bleeding, no? Cervical malignancy, again, intermenstrual or postcoital, consider cervical malignancy. So in your classification, it becomes M1. Endometrial cancer, though, is the most common cause of AUB. As we said, di ba, pagka profuse yung bleeding, you think of a uterine pathology. No? So these are your risk factors. Initially, it was thought na nasa-start siya as hyperplasia. When you say hyper, it is overgrowth, no? Hyperplasia. Plasia is growth, no? And they thought that it was a continuum from hyperplasia to your adenocarcinoma. You will have further lectures on this later, but Here also you can have hereditary causes of endometrial cancer, your Lynch syndrome, where patients have your colorectal, sometimes they have their breast. So here again are the causes. Now we go now to C1, patients who have problems with coagulation. So 20% of, usually we would want to screen adolescents, no? Especially if the bleeding started initially at menarche, yung profuse bleeding started for menarche. And these are the data as far demographics, no? Uh, for patients who have significant here is pag nakakuha kayo ng CBC na less than 10 adolescent, no? Half, 1/4 of them will have coagulation defects. 30% of those who require transfusion, so ibig sabihin medyo grabe yung AUD, and of course 50% of adolescents who start at menarche, no? So in adults, we will talk about how to, who are the patients, adult patients who will require further checkup. So okay, so these are the other conditions, no? Immune thrombocytopenia, a platelet function defect, or acquired bleeding diastasis. These are patients, aside from the von Willebrand, no? Medyo frequently encounter your von Willebrand disease, no? In patients with AUD, no? Although they become pregnant, no? So these are the things in the history that will alert you, no? So parang inano ko na yan. Meron akong isang slide again with this. Okay, so they have been trying to develop a screening tool of who should undergo with patient who of the patients with HMB should undergo hemostatic or hematologic evaluation. If your patient has menses of more than 7 days, who has impaired daily activities with most periods, no? History of treatment of anemia, a history of diagnosed bleeding disorder in the family, or excessive bleeding with tooth extraction, delivery, or miscarriage. No? So ito yon actually. Yeah. So for this is for adults, no? So usually pag adolescents, usually paggawa mo na lang. No? But for adults, this should tell you that you need a hematologic evaluation. Patient who has had a postpartum hemorrhage, surgical bleed, any type of surgery, a dental bleed, no? And that is one of the following lang. Pag two of the following, bruising, more than 5 centimeters, epistaxis 1 to 2 times a month, gum bleeding, or a family history of bleeding, then you test with what? CBC, PT, PTT, the von Willebrand's antigen, and sometimes the risperidone cofactor. So these are the things that you request for in adults. No? Okay, so I will just leave you to look at this, no, but because we have mga other things to talk about, no. So you can have disorders of platelets or platelet membrane. And now we go to your ovulatory disorders. Why does it cause bleeding, no? So itong this ovulatory disorders, this should be seen in patients who are in your postmenarchal or premenopausal, no? So kaka-menarche lang nila or malapit na sila mag-menopause, no? So extremes of reproductive life. Why does that happen? Because usually you have for adolescents may HPO immaturity, and there is failure of positive feedback of estradiol. And for perimenopausal patients, there is lack of synchronization between HPO. Yun naman yung nangyari. But if they are not in this period, no, I hope you remember this slide before from Williams, but this is in Compregain as well. Look at ovulation. So, in patients who do not ovulate, look at ovulation. Di ba, pagkatas mo mag-ovulate, so LH muna, LH, and then you ovulate. Then, after you ovulate, you secrete progesterone. Bakit? Why do you secrete progesterone? Progesterone is the hormone which will support your pregnancy. Okay, so um, our body has been programmed to do that. After you ovulate, a few days later, maybe 5 days later, then you have your progesterone. And then when the body feels that you are not pregnant, your progesterone will decrease. And this is what we call your progesterone withdrawal. And the progesterone withdrawal is the event which causes menstruation. Okay? So if you do not ovulate, you will not have this progesterone surge. Therefore, it's just going to be just a plateau, and you will not have progesterone withdrawal. Hence, you will not have menstruation. Okay? And then why do you have AUB therefore? So AUB, so after several months or sometimes years, no, of not having regular menstruation, we call it, or where you have prolonged unopposed estrogen. Kasi palagi ka lang estrogen eh. Itong yellow na to, no? So palagi ka lang estrogen na mataas. And then progesterone is the anti-hormone of estrogen, which it causes shedding of the endometrium. No? Shedding of the endometrium, um, because it causes menstruation. Estrogen, on the other hand, cause proliferation of the endometrium. So if you don't have progesterone, yung endometrium mo will continue to proliferate until it thickens, until it's very heavy, that the uterus cannot support it, and then you bleed. You have your bleeding that is prolonged. No, that is the reason for AUBO. Okay. So who will present with AUBO? Patients who have, di ba, as I said, hindi ka nag-menstruate, oligomenorrhea, no? Pwedeng irregular menstruation, and you can have your heavy menstrual bleeding pag medyo matagal ka ng palaging unovulatory. Okay? So, these are the causes, extremes of reproductive age. Because you have irregular ovulation, you can also have your hypothalamic dysfunction. We said also hypothyroidism, hyperprolactinemia, and hypercortisolism. Okay? So, these are your causes of AUBO. Punta na tayo sa E. No? So, it is HMB without other abnormalities. And these are the patients who have been previously diagnosed with BUB. So, ibig sabihin, this is a wastebasket. Wala na siyang, after you have worked up the patient really well, you did not find anything, then you can classify it as BUB. And usually, it has been seen in these patients an excessive prostacyclin production. And of course, the ratio of PGF to alpha and PGE correlates inversely with the amount of menstrual blood loss. No? Okay, but there are no specific blood tests for this. No? It's just a diagnosis of exclusion. Okay, I means iatrogenic. Iatrogenic bleeding from womb, medications usually, your pills, sometimes your mga implanon, contraceptives, no, your levonorgestrel intrauterine system, and but mostly we call this as LARC. No? Okay. No, so meron din na ibang hindi naman hormones, no, which can cause iatrogenic bleeding. What is risperidone for? Anyone aware? It's a medication for, you know, for usually sometimes used inside patients, no? Disruption in the HPO, sometimes you have an ovulation. So COC also, and sometimes the way that the sorry, the combined oral contraceptive means it has estrogen and progesterone. So, and if you have irregular intake of COC, because this combined oral contraceptive pills are very low dose now. So if you have irregular intake, you don't take it within the time that you take it, or you miss certain days, the blood levels of your hormones will um, cause the changes in blood levels of the hormones can cause AUD. Okay? And then not otherwise specified, yan, CS scar dehiscence, no? Pag natatastas yung CS scar, some AV, so again, structural, no? So this one, you can, it is diagnosed by imaging. Okay, so here, the workup, again, these are the things that you should consider doing, considering the causes of your AUD. Endometrial sampling, of course, is what we usually resort to for patients who are reproductive age. We don't usually do the endometrial sampling in adolescent girls. No? We try to be to do hormonal management. But endometrial sampling, because we want to make sure that we do not miss any form of malignancy. No? So pwedeng dilatation and curettage, no? Pwede, or a hysteroscopy. Hysteroscopy, again, the scope is inserted into the cervix, and then you can view the uterus and be able to do a more targeted biopsy. No? So now, as far as imaging is concerned, for the diagnosis, ultrasound, as we had said, meron din na I heard Dr. Munoz say sonohysterogram. You put a catheter inside the cervix and into the uterus, and then either inject a dye or saline infusion, so flu, NSS. No? And then you see if there's a polyp, makita mo siya mag-float. No? Okay, so evaluation of the myometrium, again, is done by MRI and your ultrasound, no? For your leiomyoma and adenomyosis. Now, the management, diagnosis, of course, is the key to treatment. If you have the wrong diagnosis, you will not be able to control the bleeding. No? So, and you also have to make sure that it is not a pre-malignant or malignant lesion. Hence, you don't want to, hence you need to do biopsy in most cases, especially if they are in the reproductive or very close to menopause or menopause. No? So, for acute bleeding, no, sobrang lakas ng bleeding, sometimes you can do curettage. So parang we sample, and then usually these are for older women. But you may do hysteroscopic biopsy. Pero kung malakas talaga, hysteroscope kasi puts a camera inside, but if the bleeding is profuse, you cannot see anything because of the bleeding. No? So the most effective treatment for acute bleeding in your comprehensive gynecology is the estrogen. No? However, I will show you Cochrane later and what we use really in the clinics. No? Or the combine your conjugated equine estrogen. No? So these are the things that are in your comprehensive gynecology. This is the dose of your high dose estrogen, and it shortens really bleeding time. So this is something that we use for really very, very profuse bleeding, and it is very effective. No? Even for patients who have bleeding disorders, we find this very effective. And again, for women with anovulation, we add progesterone. So let's just look at, okay. So here, oral contraceptives may be given because you want to simulate the normal estrogen progesterone cycle. No? So, but during the acute phase, you can start with your combined OCT. No? Hindi na ito yung low dose, no? Balik tayo dun sa mga traditional pills na hindi na ito yung YAS, yung Parang pwede yung Dayan, no? Dayan is because it is 35 micrograms, no? One tablet for every 6 hours. After that, no, we expect the bleeding to decrease, and then we just give it once a day. Usually, um, it would stop. No, there is no evidence of superiority of intravenous. Uh, we used to have IV estrogen, no? But we don't have that anymore. No? For patients with contraindications to estrogen, we can give your progesterone only pills. No? Ito yung mga pills that we give to breastfeeding women. No? But of course, the fastest way to stop the very profuse acute bleeding is still your curettage. Now, these are the purposes of your progestogens, no? Supporting the endometrium and an organized growth and decrease actually during breakdown of the endometrium. Okay, so uh, okay, once the acute bleeding has been controlled, no? Now transitioning to long-term maintenance therapy, usually for adolescents. Uh, Also for patients, usually as we said, for adolescents, the cause is immaturity of the HPO axis. Therefore, anovulatory sila. So what do we give to your adolescents? Yung COs, yung personally, I don't give the combined oral contraceptives if they have not reached the height that uh, ano, that is I ano for them, no? In a certain age, no, for adolescents. Because if I give the COC, a combined oral contraceptive pills, the epiphysis will close and hence will stop your vertical growth, no? So what we do is a cyclic progestogen. So kasi di ba hindi siya nag-ovulate, and you remember that progesterone is what is not secreted in your AUBO. Therefore, you give it every month na lang. For 10 days each month, for a few months, no? For 6 months. And usually, it will work. No? So this is what I use for my younger patients. If they're a little older or more than 18, I usually can ask them because COC is more convenient and it's cheaper. So, pwede na yan. Okay, next. AUBE. So ito, as we said, yung AUBE, wala tayong diagnosis talaga. This is the DUB. So if ever you are faced with this, there are things that you may think of. Oral contraceptive pills is the most common thing that they give, no? If a patient is young, again, progestogens only. Yung levonorgestrel intrauterine system is reserved for patients who have uh, who have had deliveries already. No? So, okay. Now, what is the LNGIUS? Actually, this is what has been by your Cochrane and seems to have the better alternative now. No? This is a viable alternative to your to your hysterectomy. So usually, if patients are with coagulopathy, there is a 59% reduction in MBL. So it means ayaw mo kasing mag-hysterectomy, no? And this is an alternative, your LNGIUS. Mamaya I will show you the comparison. The LNGIUS, levonorgestrel intrauterine system, secretes your progesterone. Okay, so and then it's inside the uterus. It's an IUD that secretes progesterone. So therefore, you provide what is lacking, and the progesterone which is lacking, and so that is a viable option, no? NSAIDs also may reduce MBL in ovulatory women, so patients who are regularly ovulating. However, you don't want, that's why there is a formulation of tranexamic acid with your NSAIDs that has been found to be more effective against just tranexamic acid alone. So tranexamic acid, you know what that is, your Hemostan, Hemanex, Uh, Maybe you remember your dentist giving it to you. You use it also for abnormal uterine bleeding. No? So, good reduction in your MDL. Okay. And then it is, we find it very useful even for patients with, sometimes even with patients who myomas. Let's go now to comparisons of these things. No? Uh, versus no treatment, your antifibrinolytics, meaning your tranexamic acid, for RCTs, moderate quality of evidence, higher rates of improvement. No? So very, compared to your placebo, uh, your antifibrinolytic is very good. Versus your progestogens, no? Sometimes you just give your progesterone, associated with a higher, tranexamic acid was associated with a higher likelihood of improvement. Uh, this is the data. So this one also, antifibrinolytics versus your progestogen. Uh, 61 to 83% of women uh, will will improve with your tranexamic acid. No? And of course, because your progestogens are hormones, they uh, produce some bloating, no? And for long-term progestogens, you can also have osteoporosis, no? So TXA, your tranexamic acid, has less, no? Now, comparing your tranexamic acid versus your uh, NSAIDs, no? Uh, reduced MBL also in your tranexamic acid and a higher likelihood of improvement. Now, comparing now, so parang now it is just your tranexamic acid, which has been found to be quite by the fan. But comparing that to your levonorgestrel intrauterine system, uh, higher MBL yung TXA, no? So a lower likelihood of improvement. However, there is not, as far as the adverse events, it does not say if it's equal or less. So when you are thinking of and your patient management, and your patient is a candidate for IUS, then an IUS system, LNG IUS system may be the answer compared to your TXA. No? So here, this is just a summary. Of course, these are the contraindications. GnRH agonist uh, produces your pseudomenopause. No? We don't want it because sana we just use it for a short period of time. Sometimes we use this to prepare for surgery if we are thinking of a myoma. Sometimes it can decrease some myomas before treatment, allowing us to do a less drastic surgery. So these are the examples of medications which are used to treat your heavy menstrual bleeding. Okay. Let's just go to other medications. Okay. HIFU, you have probably heard of this. This has been here in the Philippines in some centers. And I have seen how it does really help. No? Of course, this allows us to preserve fertility, and it decreases your myoma. A HIFU is just an ultrasound, but it produces shorter pulses, and the temperature is higher, no? Biglang ang taas, and then para siyang ESWL, no? May shockwave siya na kasama, na parang ano yung feeling. So these are the indications and the contraindications, no? Of course, malignancy, pregnancy, mga PID are patients that are not supposed to be done. No? These are the indications. Size of less than 12 cm. Yung iba, 10 cm lang yung ginagawa. No? Uh, in our center, not here, usually they would prefer an anterior myoma. Kasi syempre, pag posterior, mahirap, ang dami ng dadaanan. No? So, an anterior myoma is what they prefer. So there are centers with different expertise. We have this in St. Luke's Medical Center, both QC and global. I'm not sure. I think the other centers also have it. No? So these are the types of myomas that may be reduced by that. No? So, and then certain characteristics. No? But of course, it is not so the problem with HIFU is the location. If it is in close to critical structures, we don't want to use this. Of course, if it is very highly vascular, um, we are more scared. We also have that. I have seen some patients also who were not able to proceed with a robot because they did HIFU prior, sobrang bloody yung procedure. No? So, uh, maybe something that um, you have to consider. And anyway, before, we also had this medication for uterine myomas to decrease, no? Kasi, syempre, ayaw mong magpa-opera, no? So, a lot of women were given this, no, esmia, but because it causes liver failure, it has been revoked, no, suspended, but it's still available for some indications. No? It is called ulipristal acetate. No? So anyway, uh, endometrial ablation may also be done. No? Yung endometrium yung alisin mo, parang we use a machine, we have a ball with it, and then we burn the endometrium. That is, but of course now because we have the hysteroscope where you can um, do a similar yung mga endometrial destruction, no? Hindi na kami masyado yung blind endometrial ablation, no? And of course, hysteroscopy, as I said, if it is not bleeding very profusely, it is the gold standard for managing your AUD. So you can insert the camera, you have visualization of the uterus, the cavity. No? So ideal for polyps, or it can be diagnostic and therapeutic. Now, I think we have talked about this. No, the option, of course, is myomectomy. If everything fails, you're not a good candidate for HIFU, then a myomectomy can be done either hysteroscopically or open, or if you are much older, a hysterectomy or a very big myoma, no? Or in areas, uh, if it is in areas which are very close to blood supply, maybe a hysterectomy should be. So anyway, uh, this is the summary, and thank you very much for your attention. If there are questions, I will be more than happy to address them. Otherwise, you can also contact me. I hope you understood it. No? So it is, we have a very short time to discuss this, no? But you will have, so thank you for the heart. And you can, again, as I told you, it is in Canvas, no? Both the lecture and what I did for TV UP. No, that was a case-based presentation. Okay. So if there are no other questions,